Can anyone hear me?
Now we can.
Okay. Perfect. How are y'all doing?
All is well.
Good. Good seeing everybody.
So you're live now?
Still saying we're in practice session. Good evening, everyone, and welcome to Wellness on Wednesday. If you are joining us for our first Wellness on Wednesday opportunity, I want to take a moment first to just welcome you. My name is Shakima Chapman. I am the Vice Chairman of the Wellness on Wednesday committee here at Royal Missionary Baptist Church. And the purpose of our Wellness on Wellness series is to provide educational workshops to the community that focuses on health and wellness, education, finance, and mental health. And so tonight we are going to have a very critical discussion on the COVID-19 vaccine, the COVID-19 disease, and how it impacts the African American community. And I am so blessed to be joined by such an esteemed panel that will help us address some of the issues as it relates to COVID-19. So before we get started, I want to do a little bit of housekeeping before I introduce our guests. There will be an opportunity for you as attendees to answer and ask questions and address them to our panelists. If you look at the bottom of your screens, you will notice that there is a Q&A section. This is where we will monitor all of our questions. So if you have a question, please post them in a Q&A session. In the Q&A box, we have someone who is working to work through those questions, and then we will get them answered for you. If you have another question or you would like to be addressed, the only way we will be able to ask your questions is if they are in the Q&A box. So let's go ahead and get started with our esteemed panel. First, we have Dr. Thaddeus Bell. Dr. Bell is a family practice physician in Charleston, South Carolina since 1986. He is also founder of the Closing the Gap in Healthcare, aimed at decreasing health disparities in underserved communities in South Carolina. Welcome, Dr. Bell. Also on our panel, we have Dr. Shavette Slaughter, who is a physician and chief medical officer for Federal Healthcare Network. She's a native of Charleston, South Carolina, and she's been practicing in the Charleston area for the past 22 years. In 2018, she became chief medical officer. Welcome, Dr. Slaughter.
Hello.
Dr. Deanna Baker Frost. She is an assistant professor of rheumatology at the Medical University of South Carolina, and she has also been a faculty member of MUSC since 2018. Welcome, Dr. Baker Frost.
Thank you so much.
Also with us, we have Ashley Green, who is an epidemiologist with the South Carolina Department of Health and Environmental Control. She's also a COVID-19 research and statistical data analyst unit leader. Her mission is to inform the Low Countries region's targeted and strategic action against the COVID-19 virus. More than 15 years of experience in public health and biomedical research and community advocacy. She joins us tonight as well. Next on our panel, we have Ms. Felicia Vesey, who is the Community Systems Director with the Department of Health and Environmental Control. She's serving 11 counties in the Low Country region currently. She is also the COVID Response Operations Director responsible for overseeing testing and vaccination for the Low Country region. With nearly 15 years of experience engaging community, she has over 15 years of experience engaging community members to live healthier lifestyles. Welcome, Felicia. And last but certainly not least, we have April Sinclair Gilliard. She's a traveling emergency room registered nurse. She's been a traveling emergency registered nurse for the past 5 years. She is a graduate of Charleston Southern University College of Nursing, and she also has the following certifications: TNCC, ENPC, ACLS, BLS, PALS, and CPI. April, later you're gonna have to tell us what all of those things mean, but I think you are very highly qualified. So welcome tonight. I really want tonight to be a conversation. And that's exactly what we're going to do, is have a really pointed and well-needed conversation. But before we get started, we are going to kind of take this into segments. And the first segment, we want to get started. We really need to stress or give a better understanding of where we are right now. So at this time, I'm going to turn it over to Ashley Green with the Department of Health and Environmental Control, so that she can give us some statistics so we understand exactly where we are. I think, unfortunately, we've become a little complacent with COVID. So Ashley, if you don't mind, can you start us off by just giving us some statistics of where we currently stand with COVID-19?
Certainly. Thank you all for the opportunity to speak with you and to speak to the urgency of the current circumstance of the COVID landscape here in this country, in the state, and certainly in our Tri-County area. From how we work, how we learn, to how we shop, the COVID pandemic has affected most aspects of our lives, both individually as well as professionally. This is really giving us an opportunity to reimagine how we co-create the work of public health. And this is a participatory approach that's going to be bolstered by community engagement such as this, to harness and use all of the resources that we have to gain control over our current circumstance. I'm going to here. Now, you could see, please let me know if you can see my screen. All right, we're going to begin by saying this. The COVID-19 outbreak is the proof that the virus does not care who you are or where you come from. So we're going to definitely start there. Let's take a look at the pandemic summary. So we're going to look from when we had our first case, which was diagnosed or confirmed here in the Low Country in March of 2020, March 4th, 2022, just this past Saturday. This is the full pandemic summary for the Low Country, and highlighted in blue, we'll see the Tri-County area, which is our areas of interest for this evening. What we will see is over the course of the pandemic, we've had 129,933 cases that were confirmed, and we have 36,576 cases that were probable cases of COVID-19. Of those, we have 1,878 confirmed COVID-19 deaths and 246 probable COVID-19 deaths. I also want to point out the case fatality rate, which is 1.7%. And while this is not a metric for decision making, this is important for the discussion that we're having. The case fatality rate is the proportion of individuals who die from COVID-19 when compared to the portion of the total population of individuals who have been diagnosed with COVID-19. So what we're seeing now is that the case fatality rate is 1.47%. So this has gone down significantly throughout the course of time, but
there she goes.
Oh, can you hear me okay?
We can hear you now.
Okay. Well, we're going to move forward. Since the beginning of this year, let's take a look at what it looks like here in the Low Country. So since the beginning of this year, we can see that Berkeley County has had 12,000 COVID cases, Charleston 21,000, and Dorchester County almost 11,000 cases. This is half of the cases that.
Okay.
This is half of the cases that have been confirmed since the beginning of the pandemic. That's been confirmed just this year. So half of the total pandemic experience has occurred since just this January. And this includes the surges that we've experienced throughout the full course of the pandemic as well. Wanted to just give us some background before we get into some of the more close information. Okay, so this graph here is what we call an epicurve of the full pandemic experience. And what we are able to visualize with this is all of the, for lack of better words, high and lows of the pandemic. So here are all of the surges and the points in which we have returned from those surge peaks, if you will. So we had our first surge back in March, the end of March, the beginning of April 2020. We had a second surge, which is notable for July of 2020. Then we have the surge that we speak about that occurred in January of 2021, and the current surge that we are in now, which we don't know when it will peak. So if we look at where we are currently, what we can see from the epicurve that's before us is we've got more tools on board than we had at previous points throughout this pandemic, yet we're in a higher surge place than where we have been in this pandemic as well. And that should be of concern for us. So there are multiple contributors when we see spikes and surges such as this. And one of those contributors that we will be talking about, well, a couple of them that we're going to be talking about, but one of the main ones that we're going to be talking about this evening is the human contribution to these surges that we have. And human contribution to the surges would be human behaviors and factors that would be things like wearing masks, adhering to public health mitigation practices that have been recommended to us, such as social distancing and our hand hygiene practices. Also, vaccinations is going to fall in there. So this is the full scope of what it looked like when we talk about what did the full pandemic span look like. This is what it looked like for us, all the highs and lows throughout the low country. Now we're going to take a quick look of what this looked like from the beginning of this year, 2021, to where we are currently. And these are looking at the cases by weeks. So if we look at the cases by week, prior to where we are now, on the far right end of the graph, you'll see the gold bar. The gold bar is our most recent week that we've completed. So this far right end, we see that in the low country, we've had 6,476 cases that were confirmed within this past week. Just prior to that, the week prior, we had 6,813. Why that is significant is that week is the highest number of cases that we've had confirmed throughout this entire course of this pandemic. So even with the availability of masks now, even with the availability of sanitizers and the opportunity to social distance, and now we have vaccinations that are on board, we have had the highest, the last few weeks that have occurred have been the highest weeks of the entire pandemic experience for us, even when we've had those other surge peaks, which we know to have been significant for us. Okay. All right. Now, what we're looking at here, and also, if I can just back up a bit, if we look at week 24 was actually our lowest week that we've had since the beginning of the year. So week 24 was our lowest week that we've had since the beginning.
do believe we may have lost her altogether, unless it's just on my end. While we look at reconnecting her, if I can just throw it to her colleague, Felicia, if you're able to answer. At some point, the Delta variant was introduced into this equation. Can you give us a little background on when we first saw the Delta variant, and what is the difference between the Delta variant and the virus that we first saw on the onslaught of the pandemic?
Okay, so we started seeing the Delta variant in our state in May of 2021. We've had 4 variants, the Alpha, Beta, Gamma, and now the Delta. The Delta variant is what's currently the predominant variant that's circulating in the United States. And the thing about the Delta variant is that it's spreading faster and easier than the other infections. Some of the concerns is that it's spreading quicker among our unvaccinated population, and also may make people sicker. The difference in this variant too is that we're starting to see a difference in the symptoms. So initially with the Alpha variant, which is the first one that we saw last year, the common symptoms were cough, fever, and like a loss of taste or smell. Well, with the Delta variant, that symptom is very different as to what we're seeing. We're starting to see people that they're having some kind of nasal congestion, diarrhea, fatigue, and headaches. And so with that, that is how we're starting to see a difference with the Alpha variant and the Delta variant at this time.
Thank you. And as we look at the data on the screen, and of course, we can all see there's a major increase in positive cases. April, I would like to pose this question to you since you are really on the front lines. What does it look like from our hospital perspective now that we see, I mean, to see it on the screen is one thing, but can you paint a picture for us of what it actually looks like in our emergency rooms on our medical floors?
Sure. Can you hear me okay?
I can.
Okay, great. So what it's looking like in the hospitals, unfortunately, because of this surge that we have with the Delta variant that we were speaking about earlier, the hospitals don't have beds for all of the admitted patients that have been diagnosed with COVID. And so there are no beds in the hospitals, which means it's a domino effect in the hospital. So you don't have beds upstairs. So the patients that I need to get upstairs that are admitted, they have nowhere to go. So they're stuck with me in the emergency room for 2 to 3 days at a time. And so, of course, if I have 4 patients and 3 of those patients are COVID patients, I only have 1 room to work with when it comes to emergencies, true emergencies. That means people walking in and also EMS bringing us patients as well. So that in return means that your wait times for physicians are 6 to 8 hours long to see someone if you're coming to the emergency room, which at this point, of course, it's sad. And I get it. And people are upset because they're coming to the emergency rooms for chronic issues and they want to be seen immediately for pain and other things that can be handled in your doctor's offices. But, you know, at this point where we are now with COVID being so rampant and, you know, no room at the end, like they usually say in the hospitals, you know, emergency rooms are at a standstill now. And that's why you're seeing so many reports on nurses walking out. I think last week CNN reported there were 3 emergency rooms in Texas that shut down because they were smaller emergency rooms. And what they did was they shifted those patients and staff members to the bigger hospitals to kind of help, you know, get through to the bigger hospitals. So that's what we're seeing now. And a lot of the population that we're seeing as far as COVID is concerned, we're seeing the younger population come in. And when I say younger, I mean 20s to 30s, 40s. And the problem is with this Delta variant, we're seeing that they're not able to keep their oxygen levels above like what we want to see in a normal patient. So most of those patients are either on what we call a BiPAP machine that helps
move their oxygen, helps give them oxygen, or on a high flow nasal cannula. And we get up to 20 liters. We're giving someone 20 liters of oxygen to help them breathe. And this is just to get around and do normal daily living activities. We're not talking about, oh, I can't, walk a mile, or no, we're talking about, I can't get up and go to the bathroom without being short of breath. I can't get up out the bed and go to the kitchen and get something to drink without being extremely short of breath and feeling like I want to pass out. So that's what we're seeing now in the hospitals. And like I said earlier, there's no room at the end. So the emergency rooms are packed with patients waiting to be seen.
Thank you, Ashley. I think your commentary really kind of helped further paint the picture as opposed to just the data that we're seeing on screen. Looks like Ashley has returned, so we're going to let her pop back in and continue discussing the data that she would like to present. Ashley, I think you need to come off mute. I see you.
Okay. Can you hear me now?
Yes, we can.
Oh my goodness. Well, I'm telling you, I am not certain what happened, but I'm certainly glad to be back and share this valuable information with you. So basically, just sort of bringing it close to home, just wanting to sort of point out some other concerning concerns that we have here is when we talk about the deaths per week. The previous week, we had 65 deaths that were reporting. And what I want to say is this is live data. So this data changes. And of course, I want to point out the fact that the COVID deaths lag approximately 4 weeks behind the average cases. So we may not yet be seeing some of the deaths that occur from this current surge period. What we are hopeful for is that a lot of the population that were 65 and over have been vaccinated. And that's where 80% of the deaths in the Low Country were coming from prior to now. So what we're hoping is that, and what we're interested in seeing is that we may have a different outcome, but we're not yet sure. But wanted to point that out. What we wanted to definitely show, though, is that in this current week, our deaths by week has decreased. We wanted to take a look at the cases and race by race here, and African Americans, Blacks represent 25% of the population in the Tri-County area. And with that being said, when we look at the COVID deaths, and these are both confirmed and probables, Blacks are disproportionately represented in COVID-19 related deaths. So there is an equitable burden of COVID-19 deaths as it in the Black community. So here we want to talk very quickly about the COVID-19 cases by age group. And just to very briefly touch on the fact that we're seeing a changing age distribution. This isn't just happening in the Tri-County and the Low Country or in South Carolina, but this is happening nationally. And what we mean by changing age distribution is we're seeing a larger percentage or larger proportion of the population were in older age groups at the very beginning of the pandemic. And throughout the course of the pandemic, and certainly where we are at this phase of the pandemic, we've started to see an increase in the proportion of younger individuals who are getting COVID. So if we were to look at individuals less than 1 year to 18 years old, cumulatively, they made up 16.9% of the COVID cases. Within this last week, though, if we look at that same age group, they made up 39.5% of the COVID cases. So that's more than doubled. So we definitely see a change there. We do see a decrease in that 65 and over age group. They made up 11% of the cumulative cases. And in the past week, if we take a look, we see that they're making up about 7%. What I do want to say, though, is prior to now, that 65 and over, and still cumulatively in our local area, that 65 and over age group made up 80% of the COVID-19 deaths. So we're not certain how that age distribution may shift over the course of time, but certainly we're seeing a decrease in that area as well, since vaccinations and a large percentage of that population is vaccinated. One of the challenging groups I know that we have talked about, and I'm sure we'll talk about a little bit more, is looking at that 20 to 24-year-old age group and some of the challenges that exist there. So I'm sure we'll begin to take a look at some of the issues that surround vaccine hesitancy and the need for us to really put our heads together to build vaccine confidence. That is just an overview of some of the data, hopefully to give us an introduction to the COVID-19 landscape in our local area. So when we hear the numbers, sometimes the numbers can be so tiring and sometimes the data can wear us down. But what I would like to say, if anything, is that the numbers do represent people. And these people are individuals who sometimes survive and sometimes don't. And this illness is, though it may be considered an acute illness, we do have those that may have long haulers. So it's definitely in our interest to speak about the preventative measures as we move forward. But that is an overview of the COVID-19 data landscape in our Lowcountry and Tri-County area. Thank you for that time.
Right. Thank you so much. You definitely presented a lot of information. And as you were speaking, there were a few questions that came in here on our live webinar. I also want to encourage those that are watching us on Facebook or YouTube to please post questions either on the Royal Foundation page or the Royal Missionary Baptist Facebook page, and we have someone who is monitoring those pages to ask those questions as well. So I also encourage those that are here live to continue posting your questions. And I'm going to go ahead and dive into some of those questions. This question came up as we were presenting the data, and I will open it to anyone on the panel in our medical field or in our DHEC representatives that may be able to answer this question. And the question says, based on the data, it looks like more whites are dying of COVID. Was this always the case, or were we being misled initially? Dr. Bell, you look like you're itching to answer that question.
Okay.
I didn't hear the question. That's why
okay. Well, actually, it looks like you're chiming in. I will repeat it. It says based on the data, I think they were looking at the percentages. It looks like more whites are dying of COVID. Was this always the case, or were we misled initially?
Well, yes, I'll be more than happy to answer that question. You know, in the beginning, I think it was just the opposite. I think that we were hearing that more Black folk were dying from COVID, and it was mostly because of the pre-existing conditions that set a patient up to get COVID. The pre-existing conditions, right from the very beginning, have always been, the prevalence of them have always been very, very high in the African-American community. Obesity, diabetes, uncontrolled high blood pressure, and also other medical issues that patients did not know they had or knew that they had and did not pay close attention to them by going to the doctor. So when I started hearing in the beginning that we were having a high prevalence of death in Chicago, Cleveland, Atlanta, some parts of New Orleans, and other areas where African Americans lived, and the habitants, and the population was very high. I personally was very alarmed that we were going to see a major epidemic in that population of people. The other thing that kind of caught me by surprise, however, is that I did not appreciate how the living conditions of people would also play a high role in whether or not they got infected. So as time has progressed, we now know, as the presenter pointed out, that our burden of disease is really not that much different from our burden of disease as it relates ordinarily to the health disparities.
Thank you. Thank you. And I want to also acknowledge for the attendees, we do see your questions. Some are coming through the chat feature. If you put them in the Q&A feature, we will be better able to monitor and control your questions. Also, your questions will be answered. For now, we kind of want to do this in segments. So right now, we really just want to focus a lot on the disease itself, and then we will progress to speaking about the vaccine and its impact on children. And so one of the other questions that we kind of want to touch on and make sure that we get a clear understanding, it looks like, based on the data that was presented, in some shape or form, it is a possibility that we could come in contact with the disease. How do you, one, what are the most preventive practices that you can take to protect yourself from coming in contact with the disease? And then secondly, if someone in your household has been affected with the disease, how do you protect yourself? And I'll pose that question to Dr. Slaughter.
There we go. So to answer your first question, prevention is all the things that we've been talking about thus far, including vaccination being one, mask wearing being number two, trying to still provide some personal and social distancing from others, as well as trying to avoid large groups or only surrounding yourself perhaps mostly with individuals who you know are vaccinated. So and what was the second part of your question?
If someone in your household has been infected with the disease, what are the best practices to protect yourself? Because in some instances, there may not be the financial resources to maybe quarantine that person in another location.
Mm-hmm. So the CDC has put out very specific recommendations about what to do if a household member is diagnosed with COVID-19. So the first thing that you can do, and they do acknowledge, if feasible, because as you mentioned, it's not always feasible, to try to separate yourself from that individual, or separate that individual from everyone else, preferably in a home, in a room, separate room with an adjoining bathroom. Okay, that would be under perfect conditions, right? But what if mom is positive, or a parent is positive, or a child is positive? It's much more difficult to separate and quarantine yourself from those individuals. So they have two separate thoughts of quarantining or isolation. Persons who are infected, we call it isolation. Persons who are exposed in a very significant manner need to quarantine. So they have very specific recommendations. I won't get into the details of it. It's almost like it's like graphs and grids, and you have to really pay attention to if this, then that. But for the most part, if an individual in the household is infected, the recommendation, I'll just give a general recommendation, is to quarantine. All individuals should quarantine for 14 days. And that's whether or not someone in the household is vaccinated. They do recommend testing at a certain time period of that person, of the other persons, to see, because of course, if you are positive, generally speaking, you can break your isolation period after 10 days. So sometimes that might help you. If you got tested immediately, perhaps you were positive, then you know you can break your isolation in 11 days, at the 11th day. But they are very, it's buried within the CDC. And the thing that people should understand is that the contact tracers through DHAC they're really trying their best to communicate with most individuals. It's a lot, so everyone has to work together to make that happen. But they do try to communicate with individuals who are testing positive to give them very specific recommendations for their individual needs. And the school is also trying to do their part in helping parents to understand that we're sending Johnny home because he has had a significant contact with a student in his class that's tested positive. So that means little Johnny and the rest of the family members should be at home. But I'm not sure if that message is consistently getting out, because we're getting people show up at the doctor's office for a routine physical and waiting until after they've had a whole workup to say, oh, yeah, so, my daughter, she was just quarantined from the school. The school told us that she's quarantined. And we're looking at her like, you should be at home. You should not be here with me. You should not. So I think more education about that needs to go out to individuals in the school system.
Thank you. And we will definitely reserve some time to talk about the school system and how it is impacting our children. Question I want to throw out to one of our doctors here that we're being asked is, one, is the virus airborne? And then if it is, how long does it stay in the air? And then also, can you get the virus from touching different surfaces? And if any one of our doctors can chime in.
I think I can chime in on that one. So the virus is airborne, which is why wearing the face masks are really helpful. Because if you're in close enough contact with someone who's not wearing a mask, then you can inhale some of the viral particles, and then they can come inside of your body and cause an infection to happen. And that's why we think that the masks are very helpful with that. So how long that the virus can stay in the air, that's a matter of debate. They've done lots of studies in research labs, which is not necessarily real life. So it's really difficult to answer the question of really how long the viruses can stay in the air once someone sneezes or coughs, for instance. But the best way to prevent that is to wear a face mask. That way you're not trying to time how long a virus has or has not been in the air. Initially, when the pandemic started, there was some research to look at if viral particles left on the kitchen counter, for instance, or things that you touch, could you get the virus from that way? And there is, I think, a small amount of transmission that can happen that way. But again, that's why kind of hand washing and using hand sanitizer is really helpful to prevent, if you do have any viral particles and you touch your face or you touch something else, that you're immediately kind of washing your hands on a regular basis, so to prevent that from happening.
All right, thank you so much. Dr. Bell, I heard you mention the term long hauler, and we also have a question that came in. What are the long-term effects of COVID-19?
Well, now this is where family doctors get a chance to see the effects of COVID-19. These are patients who have been infected and have recovered. And now they have a syndrome called long COVID or long haulers syndrome. The syndrome can mostly be fatigue, it can be headaches, it can be muscle aches, muscle pain, it can be, you can recognize that you have a significant change in your cognition. Case in point, the first long hauler syndrome that I saw was a young 25-year-old white female who was a psychologist and got COVID early, got over it, but recognized that she could no longer do the nuances of her job. And it got to the point where she even could not manage her finances. And so she had to call in a relative. So that gives you an idea of what long hauler syndrome is about. We don't have a cure for long hauler syndrome, but new studies, there are some new studies that are showing that once long hauler syndrome, once the patient is diagnosed with long hauler syndrome and they get the vaccine, it appears in a small group of patients that the syndrome does not last as long as patients who do not get long hauler syndrome. Now, here's the other thing that I'm concerned about. I also see and do evaluations for disability. And so I'm concerned that once patients start filing for disability based on long hauler syndrome, it's going to bankrupt the system. It's going to make it very, very difficult for people who do not have long hauler syndrome, because there's a good possibility that these patients who are diagnosed with long hauler syndrome, they could be sick like this for months, okay? Because we don't have a cure for it. So that's to kind of give you an idea. The other symptoms that patients with long hauler syndrome, I have a guy that I'm following right now. Episodically, he has these intense chest pains. He's gone to the emergency room. He's been worked up several times because he thinks he's having a heart attack, which is legitimate, but he's been worked up several times, and of course he's not. I believe him. I think that he does have some long hauler syndrome like symptoms, because that has been described.
Thank you. A couple other questions that we have to the disease, and then we'll progress on to talking about some of the preventive measures that we discussed, more specifically the vaccine. Two questions. One, there's a huge misconception about catching COVID that once you get it, you cannot get the disease again. Is that true or false? So once you've gotten COVID, are you immune to it? April, are you able to answer that question? I'm sure you since you see a variety of patients coming through the hospital.
I'm sure. So the question is, once you get COVID, can you get it again? Yes. And the answer to that is yes. And as we all know, there are different strands of COVID. So you can absolutely get it again. Just because you have it in your system does not make you immune to it. Just like any other cold or any other virus, it has to work itself through your body. You know, it's all symptomatic type stuff. So yes, you can get it again. Absolutely.
Thank you. And Dr. Baker Frost, just to follow up to that question, how long, if you've contracted COVID, how long are you contagious? And then how long after you've tested negative? When is it safe for you to go around people again?
So that's a really interesting question also. And so after your test, so in order to test positive, if you're exposed, they say to wait around 3 to 4 days after you've been exposed to allow the test to become positive. If you get tested too soon, you could get a false negative test, meaning that you do have the virus, but the viral particles haven't come out yet, so they can't be detected by the test. So after you've been exposed, around 3 to 4 days later, the test will come back positive. And so that's where the quarantining period comes into play. And so after you've had your exposure and your positive test, if you wait the 14 days of quarantining, then the thought is that you are now safe to go around other people and you're safe to kind of go out and be around other people. So at that point, you're not necessarily considered contagious and that you can spread it to other people, but you have to complete the entire quarantining period before you're allowed to kind of go out again.
Awesome, thank you. One final question before we progress to the talking about some of the preventive measures. And I think this question was posed in regard to maybe using some natural remedies. Is it true that vitamins D and E are strongly recommended as a help for immunity against the COVID-19 vaccine? Dr. Slaughter, can you answer that question for us?
Well, I do know that vitamin D certainly is very important. You know, I always tell my patients, vitamin D, everyone's familiar with bone health, right? But it's also very important for cardiovascular health as well as the immune system, you know. So yes, absolutely vitamin D. And vitamin E, I probably can't speak specifically about that. And one of my other colleagues may be able to chime in. As far as studies and the data, I don't know, but I do recognize that it's important. That's just in any situation, though. You should have enough vitamin D on board.
Can I chime in on that question?
Yes, sir. Yes, sir. Of course.
The reason I want to chime in on that question is because I did a TikTok that went viral on that.
You're on TikTok, Dr. Bell?
Yeah, I did a TikTok that went viral about supplements. But as my colleague pointed out, in general, vitamins do nothing for COVID-19. They just make the urine very expensive.
So let's kind of move on to what I think you all may agree is one of the most preventive measures for COVID-19 is the vaccine. But before we talk about some of the components of the vaccine, I do want to kind of do again what we did an initial onslaught of really painting the picture. So I'll pose the question to either Felicia or Ashley. What are some statistics that we've seen in regard to how many people are getting the vaccine and who is getting the vaccine?
So I'm gonna kick back to Ashley since she's the epidemiologist, if she doesn't mind.
I'm here. Can you guys hear me okay?
Yes.
Someone decided to just pick now to apparently have an accident near my house and cause all kind of problems. So I hope that you guys can see my screen okay?
Yes.
Okay, perfect. All right, so we're gonna take a look.
We may need you to go into slide share mode to see it a little better.
Okay, how about that? Is that better?
That is much better, thank you.
Okay, very quickly, I think I'd be remiss to say this, that when we talk about vaccines, I know we're gonna talk about vaccine hesitancy, but we must know that vaccine hesitancy and willingness is on a continuum. So we have some people that may say, I'm not getting vaccinated. They may say it indefinitely, and then you may have some that with some coaching from all of us, we can all be very instrumental in helping to build vaccine confidence. It certainly may help to move them in the direction toward vaccination. So let's take a look at what vaccinations look like here in the Tri-County area.
So in the Tri-County area, what we see is that the largest population, and this is across the board in South Carolina and nationally, the largest population of individuals being vaccinated belong to the age group of individuals 65 and over. And the age group that really we are wanting to encourage and do some strong motivation is that age group that falls within that 20 to 24-year-old group. And that's among all populations, all racial populations here in the Tri-County, as well as amongst the Black Tri-County residents. So that 20 to 24-year-old age group is the group that is needing the biggest amount of motivation at this time to become vaccinated. What we can say is in South Carolina, we have 48.8% of eligible South Carolinians that have been what we consider to be fully vaccinated. Fully vaccinated means they have completed the vaccination course recommended by the manufacturer. So whether they're taking the Johnson & Johnson Janssen vaccine, which is the one shot, that one dose vaccine, or the Pfizer or Moderna, which are 2-shot vaccines, they would be considered, they would have completed those courses recommended by the vaccine manufacturer at this time here in South Carolina. In the Tri-County area, do want to also make sure that I mention, if we look at the proportion, so we talk about numbers. Someone asked earlier about numbers, and numbers and proportions are important for a distinction. So a number can be very high or very low, but it's the proportion that makes the difference in some of these cases. And so in this case, we have in the Tri-County area 702,000 individuals that have been vaccinated. And of those, 71,782 Tri-County residents have been Black. So that's about 10% vaccination rate. So we do need to really talk about the need for work to increase that rate there. So that is the vaccination rate in the Tri-County area for the total population, and then looking specifically at the Black population by age group breakdown.
So April, or any of the doctors on the panel, can you address that? It seems, of course, obviously based on the data, that it is low numbers in the African American community. What are some of the barriers or some of the reasons you're hearing that people are not pursuing the vaccine?
I'll take that question.
Okay.
We have done some independent studies trying to see why the health literacy rate is so low in African American men, particularly 18 to 30 years of age. I personally have gone to various barbershops and just sit there and listen to the conversations. It's kind of interesting. When I walk into a barbershop, the atmosphere kind of changes and people will start asking questions about the vaccine. And you can tell that something that we have found out, and that is that age group, 18 to 30, they don't look at the news. They don't read the paper. All right. If it's not on TikTok or Instagram or Facebook, they have no idea what the information is. So a lot of it comes from lack of information because they don't look at the conventional ways that the rest of us would get information. And so that's what makes it so difficult getting the information to them. The other thing is, as often times that happen in the African American community, there is a high degree of mistrust based on the other things that's happening in our world as it relates to African Americans, okay? The George Floyd thing, the police thing, Okay, all of those things contribute to the distrust that many of these young people have as it relates. And then finally, you would think, we always tell people, well, go to your trusted healthcare professional. A lot of these people between 18 and 30, they don't have no healthcare professional. So they can't go to one because they don't have a relationship with one. Their healthcare professional is going to the emergency room when they get sick. And so that has been my experience. And that's one of the main reasons why why I started going to TikTok. Since I've been on TikTok, I've gotten over 20,000 likes. I never would have gotten that, any other conventional way. So that's been my personal experience in trying to answer that question.
I'm gonna have to go out there and find this TikTok page, but you definitely make a great point of meeting people where they are, which is why tonight is so powerful. So thank you for those that are posting questions, and we're getting to them. The fastest way for me to get to your questions, and I know it's a little confusing, on the bottom of the screen you have a Q&A versus a chat. If you put your question in the Q&A, I will definitely see them. If you post them in the chat, it makes it a little harder. But we do have one really good question coming in, and they're all great questions, but this one specifically spoke to me. And it says, if you've had COVID, do you need to get the vaccine, or do you have antibodies now that once you've had COVID? Dr. Slaughter, can you answer that question for us?
So you do develop antibodies against the natural disease, the viral infection. But what we've learned over the past year and a half is that you've heard the term wanes. That immunity against the virus begins to decrease over time. And the antibody coverage, or the protection that you would get from a vaccine, stays longer. Now, we've also learned that the protection from the vaccine, I'm sure we're going to get into this in a little bit as well, has also begun to decline over the course of 6 to 8 months, because that's how long we've had the vaccine out. And like I said, we'll talk about that more, but that protection is stronger and lasts a little longer. I mean, we know that recommendations initially were after 90 days, you would be considered at risk again if you got the natural disease. I personally know 2 individuals who got COVID a second time in the 60-day window. And so the question also comes up, when should I vaccinate if I am going to vaccinate? And, the CDC said you can wait as long as 90 days, but you can have it as soon as immediately after your quarantine or your isolation period has ended. You have options.
So that does lead to questions that are coming up in the chat around boosters. So now there is a lot of discussion around boosters. So I'm going to ask a couple of questions as it relates to boosters. One, are there any known side effects for the boosters, and when can we get them? And then 2, if you got, let's say, the Moderna vaccine, do you need to get a Moderna booster, or do you need to get a Pfizer booster, or can you switch brands? Dr. Baker Frost, can you address that question for us?
Yes. So right now there are 2 boosters vaccines which are available, and only for Pfizer and Moderna. So for those people who are vaccinated with the Johnson & Johnson vaccine, there is not a booster currently available for that vaccine. The booster is actually just a third dose of the vaccine. So it's no different than the first 2 doses that was given. So we anticipate that any side effects that happened with the first 2 administrations of the vaccine could happen with the third administration. So at this time, we don't think there's any additional side effects that could happen. Most often people may complain of a sore arm. Some people may get some fevers. They may have some joint pains. They may have fatigue. Those are some of the similar side effects that people across the board have experienced with either the first, second dose of the Pfizer or Moderna vaccine. We are not exactly sure when the booster vaccine will become available. Right now, there is a booster vaccine that is available for immunocompromised patients. Those are patients that are on special medications that lowers their immune system for lots of different reasons. Either they have a transplant and they're on medications to prevent their transplant from rejecting, or they have autoimmune diseases like lupus and some other diseases, and they're on medications to treat that. So currently the CDC has approved a third dose of the vaccine for those patients because their medications prevent them from getting a really good immune response from the vaccine. We anticipate that very soon, possibly this month, those people who have gotten the vaccine at least in an 8-month period of time, which is probably our older population, like our nursing home patients, as well as healthcare workers, will be able to get a third dose of the vaccine as well. So I think right now the thought is, if you've been vaccinated and you've had the vaccine longer, about 8 months or longer, then you would be eligible to get the booster vaccine when it becomes available. And we anticipate that will be becoming available within the next 60 to 90 days for sure.
Thank you. And just want to make sure specifically that, because we had a very specific question, exactly what does the third booster do for transplant patients and seniors?
So initially, when the vaccine was made and was administered to our patients, it was unsure of what the effect would be if patients are on these immunosuppressive medicines, how that would interact with their vaccine response. And after doing several studies, they found that patients that were on these medications, they just did not mount a good enough response, unfortunately. And so that is why they need an additional dose of the vaccine. And so the thought is that with modifications of the medications based on their doctor's recommendations, they'll get an additional dose of the vaccine so that they're able to mount an effective response to protect themselves against COVID-19. And as Dr. Slaughter mentioned as well, over time, we find that unfortunately the vaccine wanes, or the immunity wanes, or it goes down a little bit. And so since our older population were the first ones to get vaccinated, they're more likely to have more of a waning response to the original vaccine. And so they'll need an additional dose to keep their immune response high to protect them from the COVID-19.
Awesome, perfect, thank you. And guys, be patient with me. I am scanning to make sure we cover all of your questions. In regard to the vaccines, if there are breakthrough cases for people who have been vaccinated, why were people told they no longer had to wear a mask if they were vaccinated? I see a few smiles coming across the screen. So I'm going to pick on you, Dr. Slaughter. Why were we told if you were vaccinated, if you can't answer that question, we didn't have to wear masks?
I think we have to understand that living in this COVID-19 pandemic it's been dynamic. It's ever changing, and viruses in general, they mutate. Every virus does. It's just a fact of life. It's always happened, will continue to happen. And as you mentioned earlier, or I think was Ashley Green mentioned earlier, the different the different types of variants that have already occurred. And that's going to continue to happen. At around the time that we saw the tremendous decrease after we started vaccinating everyone, the tremendous decrease in cases occurring, you know, everyone's feeling very confident. Oh, this is going to work. This is wonderful. However, we had that large population of those who did not vaccinate. So that allowed that virus to continue to propagate in those communities, continue to mutate. And then we discovered this new ugly, you know, virus that was stronger, more transmissible. And guess what? You would have a high enough load of that virus that even if you were vaccinated, it was just enough to kind of override the protection that you had. So it's just a matter of the various conditions that cause that to happen. So we had to quickly change the recommendation based on the change in the environment. That's probably the best way that I can explain it. So at the time, that was a true response. But then we recognize also that this is continuing to spread in our communities, people not wearing masks indoors. You know, we just had to get to a place where everyone had to do at least that minimally to decrease that overall response. So the mask, I think, is what made the difference, or could have made the difference in those who are individuals and not. I hope that, you know, I hope that I can explain that in a way that made some sense, but that's sort of what happened.
Thank you very much. A couple of more questions, which I'm happy people are very interested in learning more about the booster. The question is, what is the time frame of the protection of the booster? So I'm not sure if they mean the time frame, or I'm gonna make an assumption. The answer to the question is, once you get the booster, will we need another booster?
I think that that's unfortunately to be determined. You know, like Dr. Slaughter said, this is very dynamic. Research is happening real time. So all of the things that we're learning about, you know, and we're sharing with you guys, we're learning about at the same time. So we're not exactly sure if the COVID-19 will be something like the flu, for instance, where we have to get a vaccine every year for it because it changes. Or will it be like one of the childhood vaccinations that we get that lasts us for a good amount of our adult life? We're not exactly sure what it's going to be. We're just learning, you know, as time goes on. And I think the best data that we have is, you know, when the vaccine came out, we're just watching those people over time and kind of watching to see what their response is over time, and then making decisions over time to see how they respond. So unfortunately, I can't give an answer unless another colleague could possibly give an answer, but I can't give an answer as to how long the booster will last, just as we couldn't give an answer initially how long the first 2 doses would have lasted for.
Can I make a comment?
Yes.
Dr. Baker Frost has done an excellent job, but she mentioned flu. And I want to take the opportunity to let folk know that you will need to get the flu shot this year. It's being predicted that the flu is going to be very bad. You can get both shots at the same time. You just don't need to get it in the same arm. If you get the vaccine in one arm and the flu shot in the other arm, that's good. But if you have pre-existing conditions, the vaccine, and when I say vaccine, the COVID vaccine does not protect you from getting the flu. And people do die from getting the flu. Historically, and I'm sure our epidemiologists can probably tell us this, but in South Carolina, you know, African Americans have not gotten the flu historically like they should. So I just want to remind folks that the flu season will start next month. This is the time to get the vaccine for the flu. I just wanted to point that out, since my colleague did bring it up in her explanation.
One more question before we make a transition, because there's a lot of concern about our youth, and we do want to make sure we cover that topic before we leave. Very specific question. I have an autoimmune disease, but I received my last shot in April. Do I wait until December, or can I get a booster this month? And I think we've already possibly discussed, but I'll take it back to Dr. Baker Frost, because you spoke quite a bit on the booster. At this point, it's not available to anyone, if I'm understanding correct.
Right, it's not available to kind of the general population, but if you have an autoimmune disease, then I would definitely discuss that with your rheumatologist, gastroenterologist, whoever takes care of your disease. Because as a rheumatologist that takes care of patients with autoimmune diseases, we recommend that all of our patients do get the booster vaccine as soon as possible. And so blanket statement for autoimmune diseases, we recommend the booster shot. Obviously that would be catered to your individual circumstances and situations. So I advise you talk to your physician about it. But from a rheumatologic standpoint for autoimmune diseases, we recommend that you get the booster, and you don't necessarily have to wait a certain period of time to get the booster vaccine.
Awesome, thank you. So as we talk about our youth, and Ashley, as you're getting your data available, if you want to go ahead and do that, very quick question: can you mix vaccines, like take more than one kind? That is a question that we have.
No, you cannot. If you started with Moderna, you should.
Here.
Can you guys hear me?
Yes.
Yeah, if you got the Moderna vaccine, then your booster should be Moderna. If it's Pfizer, it should be Pfizer, but you should not mix vaccines.
Thank you. So let's make that transition. Very, of course, excited that everyone is so interested in this topic, and a lot of great questions. Some we will circle back to before we get off tonight. But Ashley, can you give us some statistics about the pediatrics that we're seeing with the new Delta variant in COVID-19?
Thank you so much. What we would like to just sort of say as we transition and flu season is upon us is we had adopted many practices previously that allowed us to reach some of the lower levels that we'd experienced throughout the pandemic. And many of those were mandated, and in many cases, some of those have been relaxed, and it's been left up to independent actions and decision-making to continue those. So we must be mindful that things like the flu, which is also a respiratory disease, was helped to be controlled by mask wearing, for example. So with individuals not wearing masks this year, that certainly increases the opportunity for transmission of the flu in addition to COVID-19. So looking at the South Carolina COVID-19 associated hospitalizations, we want to take a look at it by race. And again, what I want to point out to is the percentages here, more so than the numbers. And with the percentages, what I want to point to is when we look at the Black South Carolinians, Blacks make up about 13% of the total population here in South Carolina. So for 13% of the population to then be representing 36% of those hospitalized with COVID-19 in the state, that's a large disparity, and that's certainly something for us to be concerned about. So I want to make sure that we are looking at the percentages and thinking about them in proportion to how many to the percentages that African Americans make up or Blacks make up in the state as we move forward. We specifically were asked about COVID-19 associated hospitalizations by age group. And so if we take a look at what's happening with those hospitalizations, we talked about the Delta virus, which was first identified or confirmed in South Carolina in May of this year. And what we've seen since then is that 98.8% of those COVID cases that have been confirmed since then have been linked to the Delta virus. We've also seen that there's been a changing age distribution. And so we are recognizing that we're seeing more of the pediatric patients and younger adult patients be hospitalized than we were previously in the pandemic. So here's a breakdown of the South Carolina COVID-associated hospitalizations by age group. Some data that I can share that are more specific to children being hospitalized, and this is information that comes to us by way of the South Carolina Children's Hospital Collaborative, which is a collaboration of 4 hospitals in South Carolina, which does include Prisma as well. So Prisma is outside of the Low Country area. But when we are talking about children that are hospitalized with a COVID-19 diagnosis, as of September the 7th, there were 33 children hospitalized with COVID-19. Of those, we had 9 of them that were unvaccinated and under the age of 12. So the remainder of those were children who were unvaccinated, but they were eligible to be vaccinated. So we have to be mindful that if you have a child that is 12 and over and eligible for vaccination, that is something that should be discussed with their pediatrician, and those decisions can be made for children that are 12 and over. Then we have COVID-19 positive children in critical care. And so there are currently, as of the 7th, there were 17 children in critical care. And of those children in critical care, 9 of which are on ventilators. And so these are COVID-associated hospitalizations of children that has been provided to us by way of the South Carolina Children's Hospital Collaborative at this time.
Okay, thank you for presenting that data. And we do have a pediatrician on the line. So Dr. Slaughter, I'm gonna pose a question that's been asked. What types of things should parents be looking at as it relates to COVID? And this last part is more of your professional opinion. Do you think it's wise to have in-person learning at this time?
So what we've seen thus far is everything from just as we did with the older group, asymptomatic children versus children that had fever, cough, congestion. But the in-between are those that just had a little runny nose, a little cough. And so as most practices, we instituted screenings at the door, and the parent's supposed to circle, have you been exposed? Have you developed fever? Have you been recently hospital? All the screening questions that we're all familiar with seeing. But when you ask the parent, they'll circle it, but then when you ask them, okay, so tell me about this little cough that he's had, or, oh, it was nothing. He has allergies. So the children that are presenting to us, the few that had very, very mild symptoms, I could see why the parent probably wouldn't pay attention. So what I had to say, well, they wouldn't think that it was something that was much more important than it appears. So I have to explain to them, had it not been the era of COVID, that we wouldn't be paying much attention to it. And sure enough, some of the children that we tested were testing positive, and it's important to understand that it doesn't have to be overwhelming, some big, big bad, fever, they're in the bed, they can't stand up. It can be very, very mild or asymptomatic. And these are the children that are presenting in the schools and having, minimal, parents giving the child fever reducer and sending them to school. True story. So that's what we're dealing with right now. So I don't think, and think about it, I wouldn't say that we can't have in-person learning. We had in-person learning for a lot of our students towards the end of last year. But what was the big difference? We didn't have a vaccine, but the big difference was that we had to mask up, right? So now we're fighting it totally. I mean, like being adamant, we're not, you're not gonna, child abuse. I mean, there was the whole Daniel Island school district meeting that they had when they had, protesters yelling in the audience, child abusers, because they were telling the children or recommending that they needed to wear a mask. So I think that's the big difference. I think we could potentially do it responsibly. We've proven that that can happen. But when we just let go of all potential for trying to reduce or mitigate these illnesses or the risk, that's what we get. And not everyone has the option, right? Not everyone has the option to have virtual learning for their child.
Two follow-up questions, and I pose this not just to put you in the hot seat as we talk about our younger population, but are there specific masks that we need to use for children? Does the size of the mask matter?
The size.
Yeah. Okay. Go ahead.
Yeah, I would say the size does matter, and you can certainly find youth masks online, probably more easily than you can just finding them out in the regular grocery store. The larger masks just don't fit properly, and it allows their, you see all their little noses poking out, and I recommend doing a couple of twists just in front of the ears. Sometimes that's just enough to kind of pull it tighter around the ears. But I don't think other than that, I mean, a cloth mask is fine.
In regard to youth sports, what is the protocol for students playing sports? Is there a testing routine in place? Do you know if it's mandatory in schools that if you're playing sports that there are routine testing procedures?
I have to admit that I don't believe that there's any routine testing going on. I think that they just find out that someone's ill and they do contact tracing to get testing done as a result of that. It's more reactive than, being ahead of the problem.
Right.
Mm-hmm.
And our final question in regard to our youth, and then we'll circle back to some of the questions. I may answer this one myself, but the question is, what do we do to petition the governor and the legislator to mandate masks for all students? You do just that. You continue to legislate, you continue to make phone calls, because there is anti-maskers are definitely loud enough, and I do believe our voices need to be louder, but I will turn that over to anyone on the panel who has any additional questions. I'm going to try not to get too political for both. Pastor Holt calls me up to the altar next Sunday, but I think the best thing that you could do is be vocal. And just as Dr. Slaughter mentioned, there was heavy attendance at these meetings, then we need to be showing up at these meetings as well, if that is your belief. So before we go, we have about 8 more minutes. We do have a few questions that came in a little later, and I want to make sure that we answer those questions before we get off. Number one, April, you're in the hospital quite a bit. What type of COVID cleaning procedures are taking place in the hospitals to reduce the spread of COVID?
I'm sorry, Shakima, say that one more time.
What type of cleaning procedures are taking place in the hospitals to reduce the spread of COVID?
So cleaning procedures, what we're doing, if we have a patient that has been diagnosed with COVID, what we're doing is shutting that room down, that specific room. And we have these big fans, I forgot the names of them, but we put them in the room for about 20 minutes. So those fans circulate and they suck in air, and I can't remember the names of the fans, but you have to do that for 20 minutes. And then EVS comes down and they do a thorough cleaning of that room. And that room again sits for another 30 to 45 minutes, which again is another reason why there's such a long wait in the emergency room. All of those rooms, people come and they say, oh, I think I have COVID. I want to get tested. I was exposed. So then we have that process that we have to do when people do come in. As far as the staff, we're still doing masks, of course. We have to wear N95s, face shield, and gowns when we come in contact with anyone that's been diagnosed with COVID.
One follow-up question, April, very quickly, and then I'll throw the second half to this. Tested positive for COVID, at what point do you think an individual should go to the hospital?
So we're asking individuals to come into the hospital when they cannot manage the symptoms that they're having at home. So we say, okay, you have a fever of 102, 103, you're taking Tylenol, you're taking the Motrin, and the fever is not going away. You can come see us. We're asking if you're short of breath, you're getting up to go to the restroom, go to the kitchen, do little things, and you're extremely short of breath. We're asking you to please come see us then. If you just need to be tested for COVID because you may have been exposed, we're asking you to see the outpatient clinics for that. I know the pharmacies all have these clinics where you can sign up online and make an appointment to get tested. But definitely whenever those symptoms are not manageable at home.
Thank you. Dr. Bell, can the COVID-19 virus present itself as pneumonia, and is pneumonia contagious?
Well, it certainly can present itself as pneumonia. I'm probably not the expert on this. I think I will go back to April because she's probably in a position to answer that question a little better than I can, but it certainly can present itself as pneumonia. In fact, when I see patients who have had COVID and they've had pneumonia and they're discharged, I continue to follow them up like they've had pneumonia by getting additional chest x-rays to make sure that there's a clearing of the pneumonia-like picture that they get. So, but I think that's all that I can give you. Is pneumonia contagious? Yeah, it can be contagious. Yes, it certainly can be.
So,
I'd like to add.
I'm sorry, Dr. Slaughter, go ahead.
I was just going to add that a lot of times that by the time they get to that, they've already had COVID for a period of time. You know, one of the things that we learned now with Delta, it's a little different because they do say that everything is bigger, faster, stronger. So they tend to get sicker much, much more quickly. But I know that particularly last year with the Alpha variant, well, the Alpha or the original, that they didn't get sicker. They had the potential to get sicker later, like in the 7 to 9 day window. And a lot of times that's when they were starting to present with that. All of a sudden the fever is coming back, the cough is worsening, just as they do in a typical virus. A lot of times you have a virus, can't shake it, immune system can't get rid of it effectively. And it kind of, transforms into secondary bacteria kind of coming on board, or it could even be viral pneumonia. I guess that's what's happening with this newer variant, the quicker, faster, it's not really, they may not respond specifically to antibiotics because it's considered, I think, viral at that point, but it's just affecting those airways in a way that we haven't seen before.
The other thing you have to keep in mind too is that, if a lot of these patients have pre-existing conditions like asthma, a lot of adults who smoke, in the very beginning, we were very much aware that people who smoke were very susceptible to getting the virus. So anything that's going on with the lungs, because that's one place the virus likes to go and replicate and cause this damage. So absolutely.
And I wanted to add to what they were saying about the COVID pneumonia. That's why we're asking you, if you've been diagnosed with COVID, to try to sleep either on your side to side, and on your stomach, not on your back, because that's where most of your lung capacity is. So as we treat patients that have COVID, we ask them side to side and stomach. Try to stay off of your back as much as possible.
And April, can you stay right there? Because one follow-up question in regard to symptoms. How do you distinguish sinus allergies? How do you distinguish the symptoms between sinus allergies and COVID? The person is saying it seems that they're pretty similar: cough, chest congestion, headaches. How do you distinguish, and should you be distinguishing?
Right. So unfortunately, because, you know, these different illnesses have the same signs and symptoms, there is no way to really tell unless you get tested. So again, if that is the case and you're having symptoms and you're not sure if it's just my allergies acting up, you know, you're just really unsure, then definitely get tested. And like I said, there are a lot of outpatient clinics that are doing the testing. Most of the times with viruses, especially with COVID or the flu, you'll see a fever, but not in, mostly when you're having allergies, you don't see that fever, is what we're seeing anyway. But it's hard to tell the difference, of course, because everything's about the same, but get tested if you're unsure. And in the times that we're living in now, everyone's unsure. So definitely get tested.
And I just want to add, as far as testing, April's mentioned the outpatient clinics, but DHEC also has clinics at their health departments and also testing at different sites across the Tri-County area. So the testing is free, and we have a little bit of wait, but as far as waiting to get tested, but it's not as long as you would have to wait, possibly going into an urgent care facility when they're trying to treat other conditions. And also FEDER also provides testing several days out the week for a couple hours in a day. So you have options out there. You can find the information on our website.
So that is, can you give that website, Felicia, if you don't mind, where they can go to find free testing sites?
Yes, it's scdhec.gov/COVID-19 testing locations. But when you go to the COVID-19 page, you'll click on the middle, it'll say testing locations, and you'll see it there. It also has our vaccination sites as well.
And we will be sure to get that.
I can put it in the chat as well.
Thank you. And then one more question, Felicia, and then we're going to close our questions. We have 3 final questions and we're going to close. So I ask you guys, give me a little grace. We're a little over time. Are there home test kits? And then I'll just follow up this question as well. Are air purifiers effective at home and work in prevention?
We do have home test kits. There are saliva kits that we provide at our different health departments. If it's a day that you just don't feel like getting the PCR test or getting swabbed on site, we have saliva kits that we can share or give to you. You can get up to 5 kits per individual to have for your family. As far as the air purifier, that is out of my area, so I'm going to send that one to a physician.
Dr. Slaughter, Dr. Bell, Dr. Baker-Frost, can either of you speak to that?
Well, I'll let you know that it's been recommended that wherever there is good circulation of the air, you decrease your risk for infection. You know, we just had the Low Country Jazz Festival here in Charleston this past weekend. And one of the things that we made sure that happened was that the ventilation system at the Gilliard Auditorium was working quite well. So they do recommend that good ventilation, movement of the air decreases your risk for infection.
And one final question, and I'll open to anyone who's had experience with this population. As far as pregnant or nursing mothers, can they receive the vaccine? And if they do, what are some of the risks and side effects?
Yes, yes, yes.
Yes, yes.
Please
yes.
get the vaccine. The side effects are going to be very similar to what everyone else is experiencing. And pales in comparison to the severity of the illness that that mother and her baby could experience as a result of getting COVID-19.
Thank you. Well, I must say this has been very informative, and we are very grateful. I know I speak on behalf of our committee and our pastor. Just thank all of you for taking the time and really providing education. And then I now challenge those that are on the call and receive this valuable information to help us spread this message, point people back to the Royal Foundation Facebook page, as well as the Royal Missionary Baptist Church page and our YouTube pages, and share this information. I think more than enough misinformation has gotten out. And so we ask that you just do your part and help us share valuable information. I'm going to go around the room and I'm going to ask very briefly if each panelist, and I know this is going to be hard, but under 20 seconds, give us one closing remark or one thing you want them to walk away from. And I'm ribbing Dr. Bell. He cannot repeat what he said on his commercial. So we'll start with, although it was very effective, it was very effective. But if you want our attendees to walk away with one thing tonight, what would that be?
Well, I would say that if you love your family, you need to take the vaccine, not only for them, but for yourself as well.
Thank you. Dr. Baker Frost.
So I concur with Dr. Bell, and I often tell my patients that I know that you're afraid of the vaccine. I was afraid when it was time for me to get the vaccine, but I didn't want to tell my patients to do something that I was not willing to do. And so the vaccine is very, very important.
I can go. I'd like to remind families and patients in communities that the vaccine does what it's supposed to do. It's supposed to reduce significant illness, hospitalizations, death. It's important. Even if you happen to get it with a breakthrough case, it's still worth the vaccine. Get it.
Thank you. April?
Sure, I definitely wanted to just jump on the backs of what everybody else has been saying. Get vaccinated, please, so we can get a hold on this thing and it can get behind us and we can move on. Get vaccinated, please.
Alicia.
Amen to what everyone else has said. I too was afraid to get the vaccine at first, but I recognize the position that I hold in the community. And so with prayer and research, I decided to get the vaccine. And more so for me, it was more of a selfless decision, recognizing that I have family members and friends that have underlying conditions. And so it was about making sure that I was protecting myself first to make sure that I was protecting them. So I encourage everybody to make that selfless decision and get vaccinated.
Thank you. Thank you once again. And Pastor Holt, I cannot let you off the hook. Can you close us out in prayer?
Yes. And also with a comment, I want to thank all of you for being a part of this telecast. If my grandmama was still alive, she would do a backflip to see these African Americans in the positions you are, that her generation never saw this. They dreamed it, but we are blessed. And let me say, from my talking with the public, that people can be persuaded, but it's only going to happen with what we are doing right now. We're going to have to come out, preachers too, have to go to barbershops, come out from our offices and our Mercedes and our people are hesitant. But I found out many of them are very intelligent. They're not just stupid. You know, you're going to have to convince them. We're going to have to convince them to save their lives because they are very suspicious. They're very hesitant. and they not all are not naive. They're just getting wrong information. And the only way to counter wrong information is with right information. As Dr. Bell said, many of our the truth is a lot of them don't have a personal physician. They don't have a doctor in their family. You know, they just have people next door. And there are some very people that do a lot of research. You have to really dig. You have to know your facts, which we have here tonight. That's how you have to convince people, because they got questions. As Shakima said, they're going to ask some questions. I was talking to somebody, he was giving me the statistics from the results in Israel and Britain and everywhere else and this and that. And I had to go research. We have to come back and convince them. So I just want to thank you. The breakthrough cases are going to happen. Remember when the vaccines came out, 93% is a miracle. A 93% effective rate for a vaccine means that 7 people out of 100 might catch it. But 93% in dealing with vaccines is one of the highest good rates of any vaccine out there on the market. I think most of our medical people will say that. We just see a few breakthrough cases, not a few, that each one is important, but 7 out of 100 might get it. 93 out of the 100 won't get it. That's what we need to do. And if we didn't have the vaccine, we would have body bags laying in the streets right now. Let's be real about it. The vaccine is what has caused us to lose, helped us to save 1 million people. So thank you. Thank you for coming. Nobody getting paid that I know about. You're doing it because you care about your community. This is really giving back. And nobody expected this when you went to college. I know you didn't, but this is giving back. This is giving back, and it's going to take this to help save the African American general population as a whole. We got to go to them. We got to get the right information to the right people, and we can't sit on it. We got to research it. We got to do our research and bring them the numbers, and they can be convinced. And I'm closing now. But if you notice, I know
he is a Baptist preacher. He gets multiple closes.
We work with DHEC and FETA. And I know Felicia and Sister Aretha Powers will both ascertain that when they brought the vaccinations and the testings to the Black church, the numbers went up tremendously compared to the airport and the Gilliard Auditorium. It's because our people need that level of confidence. They need to see you get a shot. You know, and one of the biggest things you can do to convince somebody to say, I took the shot. I took it. And that helps a lot of people. Father God, we thank you for tonight. We thank you for this wealth of information, not only information, but frontline experience, that we pray somebody will be saved by teaching their child how to wear the mask correctly, by wearing their mask and not letting it be a sign of weakness, but a sign of faith. And Father, we pray that everything that was said tonight would be multiplied 100 times, like the 2 fish and 5 loaves, that it was spread through homes and communities to save lives. We thank you for this Royal Foundation and for all of these that participate. In Jesus' name, thank you, Lord. Amen.
Amen. Again, thank you all. And we just ask that you continue to support this ministry as we continue to address important topics such as this. So you can find us online at wellnessonwednesdays.com.